This is brief coverage of the section in the workbook on radiology of the sacroiliac joint. And we spoke earlier about the fact that a CAT scan or an MRI is going to give more information about inside the joint than a uniplanar view with X-ray. The book Dillman's 1979 Diagnostic Radiology, the sacroiliac joint, would be one of those great books to bring up, redo. I haven't seen the second edition, but it's still an interesting text. One person, Davis and Lentil, actually, both persons studied 50 female pelvises, and then a control group of 66 asymptomatic females. And bone scans were positive only in 2 of the 66 asymptomatic for sacroiliitis, whereas 22 of the 50 were positive for unilateral or bilateral sacroiliitis. Radiographs were negative in 20 of the 22 symptomatic females with positive scans, and therefore radiographs, X-rays, are very limited in detecting low-grade inflammatory process. And in this study, they had a negative HLA-B27 antigen, and it was concluded that SI disease is a common cause of low back pain in women, and that bone scan should be given consideration when X-rays are negative, and that this problem might be more common than is generally suspected. And of course, the reading of a bone scan can be subjective if done visually. So I haven't seen that study replicated, but it's still worthy of consideration. And the images in the radiology section of the workbook are informative and worth taking a glance. And sometimes what you'll see in a standard AP of the pelvis, you'll be able to measure the width at the mid part of the pubic joint. Just a week ago, I evaluated a person who was unable to walk and unable to sit due to generalized low back SI area pain. And I found that the entire left side of the pubic structure had shifted posteriorly, and that the right pubic joint had shifted inferiorly. And we evaluated her on day 1 and treated her on day 1. And she was seen 3 days in a row and made significant gains in her ability to walk and her ability to tolerate sitting. And very soon we're going to post those images. After her first visit, we loaded up the films and reviewed the MRI and the X-rays, and it was remarkable because this was the first time that I'm aware of that there has been interesting correlation between the X-ray images and what's found with the clinical exam. I hope to publish that. What was really interesting is that the AP film of the pelvis showed symmetry. The other views that were taken at another angle demonstrated that inferior shift of the right pubic structure. It was not subtle, it was very obvious. The MRI images showed the posterior glide shift of the left pubic bone in relationship to the right one. And a couple of years back I posted a YouTube video questioning the ability of a standard AP of the pelvis to really capture dysfunction in the pube, because it's a rounded structure, and for that reason one could have a vertical or a rotational dysfunction that would be missed based on the angle. and my conclusion was that perhaps the X-ray beam should be perpendicular to the angle of the joint, whatever that is, measured prior to it, obviously. And so it was very interesting to see that in one image this person looked to be symmetrical, and in two other images taken at different angles you could see that vertical dysfunction. The injections are in the SI joint, of course, are being done with fluoroscopy and used with dye to visualize the joint space. And I think there are protocols in the X-ray literature for evaluating vertical instability of the pubic joint. And of course there is some interesting work in the orthopedic trauma literature in looking at pubic joint instability. And when someone suffers an injury, such as a motor vehicle accident, that causes rupture of this joint, in the field, the EMTs will put a pelvic binder on that person. So by the time they appear at the emergency room and undergo X-rays, there will be some elastic recoil, and the degree of separation of that pubic joint will be altered. It will be reduced. And there is one case in the literature where a person appeared to have pubic joint dysfunction measured by 10 millimeters or less separation. Pubic instability, the norm for surgical stabilization tends to be 25 millimeters and above. Otherwise, the person should heal over time with a compressive belt worn low. In this case study, based on the person's symptoms, of course, the degree of separation did not match the degree of functional loss, inability to ambulate, etc., pain, etc. So the researcher, the clinician, compared those X-rays with a repeat X-ray done with manual stress applied to the joint, and the gap increased significantly. So I believe that in the clinic we're going to encounter some of these people who have been underdiagnosed, who clearly have instability in that joint. And what we can do is put a pinky finger in the space, in the interjoint space over the fibrocartilage, and then impart a manual test on one side, rotational and also lateral, so a parasagittal rotation and a lateral force, and discern if there's deformation at the joint, and then repeat the same thing on the other side. You can also use a depth gauge and measure the depth of that fibrocartilage, and refer out, of course, for additional workup if you do find excessive mobility there. But this serves as a very brief introduction to radiology, and I think we've covered some of the more salient points. Thank you.